Hello and welcome to a City Voices interview with Dr. Danielle Knafo. And I did get that right? Okay, Knafo. Very good, very good. So let's
Knafo,
dig right
yes.
into this interview and I will find my questions. All right. All right. Are all
You're
your
freezing a
patients? Oh,
little.
and Dr. Knafo is a clinician who works with for many years patients with psychosis. So, Dr. Knafo, are all your patients experiencing psychosis?
Not all of them, no. That would be a difficult practice. No, but I've always had a number of patients who either experience psychosis or I help them through the psychosis and we continue working post-psychosis.
So, did you specifically seek out patients who were going through psychosis, or did they just happen to pop onto your chair?
Well, one never knows, but I didn't seek. I worked, in hospital settings for a number of years, and I've taught to students, doctoral students in clinical psychology. I've taught them how to work with serious mental illness, particularly psychosis, for 22 years, and so I've given lectures on the subject. Some of my lectures are on YouTube. And so
All
people
right, Dr.
find me.
Knafo. I'm sorry to
Yes.
interrupt, but we only have we have less than 50 minutes and we have to breeze through a number of questions. Why the interest in the psychotic experience, Dr. Knafo? Knafo.
That's okay. Um, okay, you cut me off here. Why the interest? I've always found it interesting. I'm interested in creativity. I've always been interested in the psychology of creativity, and I find psychosis has an element of creativity in it, creating alternate worlds, creating, using certain defensive mechanisms to create adaptation to very difficult, sometimes unbearable situations. So I think that was my entry into the interest in psychotic experience.
So under what conditions can someone become psychotic?
Oh, I don't think there's a specific condition. Many people have experienced trauma, uh, especially in their childhoods, that can come back later in a psychotic form. I think trauma is definitely related to the onset of psychosis, but it's not the only thing. Smoking marijuana, we've discovered, can result in psychosis, especially if someone begins smoking marijuana early in life and becomes quite addicted to it. That can lead to psychotic experience as well.
What have you learned from speaking to hundreds? Now, it is hundreds of patients in their psychotic states, right?
Hundreds, probably. Yes. What
So
have I learned?
what have you learned? Yes,
I've
from
learned
them.
many things. And you cut me off from my previous question. This is a much longer answer. I think what I've learned is, to make it very, very brief and to the point, is that psychosis is a way that people try to cope with unbearable emotional or traumatic situations, and they make meaning through psychotic symptomatology. And so the therapist's challenge is to connect with that person, try to help them understand how this form of adaptation has been helpful to them, but may also have been limiting and harmful to them.
Can you give us an example of how one of your patients is trying to make sense of a trauma, and how it appears to you, you know, so they experience a psychosis, and that's like based on what you said, it's a way of trying to come to terms with a past trauma. And how do you, as the clinician, go in there and interpret the psychosis in a way that's meaningful therapeutically?
Okay. You're asking very good questions, but they're also very big questions that require time to adequately respond. I have written a book recently on the treatment of psychosis. So if any of your listeners are interested in a more detailed response with a lot of clinical examples, I would recommend reading the book. But how do I interpret? So I don't jump in and interpret. I follow the patient. I try to get to know my patient. I enter their world with them. I try to establish a therapeutic alliance with them. I want to know from their perspective what they're experiencing, how they see the world, how they're using certain defenses to cope with the world. And it's only, you know, so I take the patient's lead. I don't lead so much. But together, I see it as a collaboration. Together, once we establish a good working relationship, we then can enter maybe some more painful places and start looking at what these defenses or constructions, how they're serving the person, and what the meaning that they have for the person.
Do people in psychosis have something they desperately want to communicate about their experiences? Like really desperate?
I think yes. I think yes. And I think that what people see as symptoms, psychotic symptoms, are ways of communication. Most symptoms, whether they're psychotic or neurotic, are communication measures. And it's up to us to listen to those forms of communication rather than get rid of them. So the medical model tries to get rid of those forms of communication. They give medication to get rid of the hallucinations, to get rid of the delusions. And to me, that's the inroad. If you get rid of it, how are you going to understand what the person is doing and what you're saying, the desperate message that they're trying to get across? Their way of communicating, of making meaning, is through these symptoms. And so if you just get rid of them, you actually get rid of a lot of the material that can be useful in the treatment.
So do you see psychosis as a process of healing?
It's an attempted process of healing. I would say of coping. The therapy helps to use the psychosis to heal. But I think the person who develops psychosis and psychotic symptoms is trying, I don't know if they're trying to heal themselves, they're certainly trying to cope with a difficult situation. And this is the way they do it. To heal, I think, is where the therapy comes in.
And unfortunately, some of the side effects of psychosis are, you know, behaviors that could be very harmful and dangerous to the person experiencing them, even putting their lives at risk. Yeah. So is it not a wise measure to medicate and remove the psychosis altogether?
Well, I don't know if one can remove a psychosis altogether with medication. One can reduce the symptoms, and not all symptoms are responsive to medication. But I agree with you. I'm not anti-medication, but I think a lot can be done through talk therapy, and one doesn't have to resort to medication as the first order of business. But I think when there is danger involved, either danger to the self or to someone else, that we do need to perhaps take more drastic measures, use medication to stabilize a person and get them to a place where they can work in talk therapy.
Well, even if there's not, a danger to oneself or others, speaking as someone who's experienced psychosis a number of times, there is still, the trauma, the traumatic experience of the psychosis itself. It's funny that you say psychosis is a measure of coping with trauma, and yet the experience itself can be very traumatic too.
That's
And
true.
not only to the person experiencing it, but also to the family and everyone who
Yes.
loves them. So,
Yes.
so it's
And
not just a matter.
the treatment can be traumatic as well. The hospitalization and the treatment, it can also, I've had many patients being traumatized by that. So it can be trauma on top of trauma.
It's really sad. I mean, but how can you meet with a patient maybe like once a week, and is that, well, okay, sometimes more, and how
many times more.
all right. So how effective is that in actually helping someone through and past a psychotic experience that could last sometimes for years, right?
Yeah, yeah. You're asking very good questions. And I sense your skepticism too. And it's not uncommon, this kind of skepticism, which is why I wrote the book. First of all, I see patients sometimes I see patients 4 times a week. I see patients when they're going through a psychotic episode every day, or I'm in contact with them every day. And how does that work? Relationships are healing. You work within a relationship, a trusting relationship, a caring relationship, a relationship that's trying to make meaning of the person's experience. We're doing it together. I give the person as much personal agency as they can take, and so these things are healing over time. If it's somebody is having a first episode psychosis, usually if you can get in there very quickly and work intensively with a person, you can, I've found that we can turn that around within 6 months or so. And that's very important. Instead of, I'll just medicate this person and, afterwards, after they're stabilized, they'll do therapy. No.
Well, hold on. You said you can make it turn around in 6 months, first episode psychosis. What does that turnaround look like? Tell us about it. What's the recovery?
They come to understand what the psychosis was about, what triggered the psychosis, what's the meaning of their symptoms, how they were using the symptoms to try to both comprehend, communicate, and cope with whatever it was that they were trying to cope with. That understanding and the sense of being taken seriously, because so many people, when they encounter, including professionals, when they encounter somebody who's experiencing psychosis, they will just dismiss what they're saying, not pay attention to what they're saying as a form of communication. They will say, well, they're speaking gibberish. And instead of saying there's meaning in their symptoms and what they're trying to communicate through their symptoms, even if you don't understand everything in the beginning, you have to be patient and be there and listen. So
I'm sorry. Go ahead.
I'll give you an example of that.
Yes, that's what I wanted.
I know. So students tell me, well, what if somebody's just, speaking in a very disorganized way? And how do you make sense of that? Not everybody has kind of these coherent systems, even if they're not seemingly realistic, consensual reality I'm talking about. Well, you listen, even in like word salads, you may get lost listening to that, but then you hear, oh, this person keeps repeating one word or one phrase. That must have some significance for that person. You pick that out you repeat it back to the person and say, what is the, what does this mean to you? And then they can start, you start elaborating on things, but you have to listen. You have to be willing to enter their world. You have to be willing to listen, and you have to be willing to not understand everything in the beginning. You have to tolerate ambiguity and confusion in the beginning. And
not every clinician can do what you're doing. And do you know why?
I think because people are, first of all, people are not trained well. And so when they're confronted with psychosis, they get afraid. They're afraid that there's contamination. They're going to become psychotic. They're afraid that they're going to be de-skilled. Everything they learned, suddenly nothing is working because they're trying to apply certain skills that work with other types of issues with a psychotic situation. And you have to know how to work. So I think the majority of the reason people are put off or scared or quickly medicate is because they don't feel, they're not trained. They're not trained for this kind of work.
And it sounds like it's much more intensive work. And sometimes you're meeting with a patient for 4 times a week. And also, it requires an extraordinary amount of patience, which people don't have.
Patience and dedication.
Dedication. But let's get back to that example of the first episode person who came to you, and in the 6 months you helped to turn it around. Did turn it around look like a total elimination of all psychosis symptoms and resuming one's normal life?
It certainly results in resuming one's normal life. First episode psychoses usually occur in late adolescence and early 20s. And many times the onset is when young people go to school, go to college, they're separated from their families, there are new demands on them. And for certain sensitive people, they can feel overwhelmed with all this, the social demands, the sexual demands, identity demands. They never had to, stand on their own with this, and they break. There's something breaks, something fractures. They start taking drugs, alcohol. All of this can cause a first episode. So often these people leave school. They leave and they come to me. That's when I see them. And I'm glad to see them right away. But first of all, many of them are hospitalized. They're given medication. They're told that you have to be on this medication for the rest of your life. They're told you have something like diabetes. They're diagnosed with schizophrenia and told they have schizophrenia. And they're told this is a lifetime chronic disease. They come to me with all of that. And they're overly medicated, most of them. And feeling lost, feeling confused, feeling, like they're failures because they started this school autonomous life and now they're and so first of all, I disabuse them about the idea that they have an illness for the rest of their lives, and that I tend to see psychosis as also episodic, especially in the first episode. There's an episode. Depression can be an episode. Psychosis can be an episode. If you look at it that way, then you're not instantly putting this person in the category of lifetime chronic illness, because you're gonna treat them very differently if you see it as, oh, you've had an episode, something happened, and the more you can identify what happened and what triggered it, the better prognosis there is than if it was like a gradual retreat from reality over many years and you get somebody later.
So when a young person comes to you and they've been through the system, they're starting their journey through the system and they're heavily medicated, how do you help them through psychosis when they're so heavily medicated? Does some of the psychosis
that's one of the first orders of business, is to reduce the medication.
And then
because
some of that
they feel that they can't think. They feel that they've lost touch with their own brains, with their own minds. And so not only did they have a psychotic episode, now they're having a reaction to being numbed. Many people say, I feel like a zombie. I don't know who I am anymore. And the first episode, why do I say this is relatively easy to treat? Because when somebody first becomes psychotic, they have one foot in consensual reality and one foot in the psychotic world. And they're confused. They know that something is happening to them. They know that they're not functioning the way they were, or that they can't connect, or they're not, strange thoughts are happening to them. There's a knowledge of it. It's only after a while, if you let them go without therapy, that they start making sense of it in a more psychotic way. They can create delusions to, okay, now I understand why I was feeling this way. Now I understand, but it's a psychotic solution, right? It's a psychotic.
Why do some psychoses last longer than others, like much longer?
Yeah, that's a good question. You ask such good questions. This is a whole course to answer your questions. Why do some last longer than others? Well, there are a few reasons, okay? One is, like I said, when people have a more acute psychotic episode where you can identify the triggers, and this is true with any disorder, the quicker it comes on, the quicker it can resolve. It's when there's a gradual onset over years and years and years, where a person starts retreating, is more confused, has more of a retreat from reality, from people, from society, that it becomes much more ingrained. And by the time, they're treated, let's say if parents don't step in early on, then they've already been in a system that system creates a chronicity of sorts. Also, it convinces them that it's chronic. And so that tends to last longer. There's also a biological component in some people that's stronger than in others. And so, that can be a factor as well.
Is the general public safe from most people who experience psychosis?
Yes, absolutely. But there's a lot of myth around that. But most people who experience psychosis, if anything, if they're dangerous, they're more likely to be dangerous to themselves than to other people. And so the fear of psychosis, I think, just comes from the strangeness of it, the incapacity to understand what is happening. When we don't understand what is happening or how a person behaves or speaks, we often get afraid of it instead of, that's a natural instinct, the fear of it. And then we might say, oh, this person is dangerous. They might not be dangerous at all. They're just confused, or they're in their own world, or they're creating, people aren't educated enough about what psychosis is about. So they go to danger.
Mm-hmm. But what can be dangerous to the experiencer of psychosis and those around them?
Okay. What can be dangerous is sometimes people create a delusional system, for example, and in that system, or they have hallucinations with voices that tell them to kill someone, to kill themselves. And they feel that they have to act on that. That can be dangerous. That can create, the son of Sam was told, he heard his dog's voice telling him to kill people, and he went out to kill, and he killed people in a psychotic state, convinced that the dog was correct. So those kinds of things, they're extreme. They don't happen with everybody who experiences psychosis, but it can happen. Some mothers are told, they hear voices to kill their babies, or things like that. Those are dangerous situations. So you want to be very alert to that and see any kind of danger signs that would need an intervention, a stronger intervention.
Have you ever had, were you, was your hand ever forced to seek out stronger interventions for certain patients?
Um, one time, you're asking me about like in my private practice, because obviously
Yes.
when I worked in hospitals, the intervention was the hospital had the safety. Uh, but one time a patient was, in danger, living with family, and had a delusion that he had to um, light candles all the time, and there was some danger that he could burn down the house, and so the intervention was to have him hospitalized at that time. That was the only.
How did that feel to you as someone who had to get someone hospitalized? You're one of your patients.
Yeah, it was not easy because he was the only one in my whole experience of 40 years. The only one.
And that's very telling because that goes to show that the myth of violence is pretty rare even among people with active psychosis.
Yeah,
Uh,
I would
okay,
say so.
so we have a lot of questions here. We're not going to be able to get to everything, but
No, we won't.
I'd like to get to some that are very interesting.
Okay. Oh, so people
Okay.
are sending in questions?
Oh, well, yes, but I'm channeling them, and I wrote these
Okay.
ages
Pick and
ago.
choose. Pick
So
and
when we
choose.
first started communicating, I wrote these down, and so Joseph Campbell has this quote as saying the psychotic drowns in the same waters in which the mystic swims with delight. But I ask you this, is it possible, can someone in psychosis actively engage in exploring their psyche, whether with a partner such as yourself or by themselves?
Yes. Yes. Not everyone, but yes. Yes. And you want to facilitate that with the patient. Not everybody can, and certainly not in the beginning necessarily, unless they're right at the beginning of the onset of psychosis, because then, as I said, they have one foot still in consensual reality, and so you can start asking them about, can you look at that? Can you think about that in a certain way? Once somebody is more fully in the psychotic episode and without that foot outside, then you have to work with them from within their world, and that's a different state. I forget what your question was.
That's okay. Let me repeat what Dr. Joseph Campbell,
Oh,
who is
Campbell,
the
can you do it from
mythologist,
within?
he
Yeah,
he had
I
he
know
was
who Joseph
Oh,
Campbell is.
okay, of course you do. So
Yeah.
he had a wonderful statement that was the psychotic drowns in the same waters in which the mystic swims with delight. So do you see psychosis as this ocean and patients are drowning and you're there to teach them how to swim?
It's a metaphor. It's a metaphor. Not everyone's drowning who's psychotic. Not everyone's drowning. You're focusing a lot, and you use the words drowning, desperation. Some people are desperate. Some people are not. Some people are happily psychotic. They found a solution. They found something that makes sense to them, and it's other people who are bothered by it, who say, this person doesn't live in the real world, or this person needs help, but they can live, more comfortably in their world. Most people experiencing psychosis, however, do experience fear. Bertram Karen, who worked a lot with psychosis, said the one thing you can be sure of, only one thing, when you're dealing with psychosis, and that is that they are afraid. You can count fear.
So if you remove the fear and perhaps remove the delusions too, and you leave the other parts of the experience, the visions and the voices, just those experiences, do you have someone who's more of a mystic than a psychotic?
Mm. Well, that's a good question. Um, I have someone who, a former patient of mine, who contacted me this week actually for a referral for a friend, and who told me, that we did a lot of very intensive work for years, and then he went on his own. It wasn't all resolved, all of his issues, but he was functioning in the world. And he wrote to me how much Christianity has helped since since leaving the treatment. And he had some trauma, family trauma, after leaving the treatment. And so we're going to speak soon about how that has helped him. Because I like to have follow-ups with patients, even after we've finished work. I like to hear from them, because it's helpful to me too, to know how they've progressed or stood still or had problems or resolved certain things. One never resolves everything. That's
All
life,
right.
being
So,
human.
so if a patient comes to you and expresses that they're speaking to their dead grandmother or some ancestor or someone even from the future, do you dismiss that? Do you dismiss that as not possible in
No,
reality, or as just something expressing itself from the psyche that's more archetypal than reality?
the latter, the latter.
Oh, okay. So it's more archetypal.
Yeah,
It's
I
more
don't dismiss
metaphorical.
it. I don't dismiss it as unimportant or irrelevant, but I don't consider it, that they're communing with the, as you're asking me these questions, I'm thinking of Carl Jung, who was very into mythology, and he influenced Campbell quite a bit with the archetypes. And he had a psychotic episode, and which he documented in his Red Book, both in writing and in imagery. And he compared it. He said, I'm having these experiences that my patients who experience psychosis are having. And what does this say about me? But he felt it was also extremely mystical. And so, and he worked through it. He was working during the time that he was having these experiences and documenting them. Not everybody can do that, but he was at that level that he was able to, function in one world and still have these really out of life experiences in this other world and document them.
Was he working with psychosis patients while he was experiencing
Yes,
psychosis?
yes, he unlike Freud. Well, Freud worked with psychosis, but he thought you couldn't. But Jung always had patients with psychosis. Yes, yes.
Oh, and how did it, do you know how it affected his approach to psychotic patients when he was experiencing it himself?
Hmm. Um, I don't know that he connected it immediately. I know in like seminars or things he spoke that he had these experiences. So he didn't hide them, although his family hid the Red Book for many, many years. They didn't want people to know. And only a few years ago, it was revealed, this masterpiece. It's really an incredible work by this genius, and who had these experiences and was able to communicate them and visualize them. And it's incredible, but they kept it hidden for decades because they didn't want people to think less of his theories and his writing, knowing that he had these experiences.
The Red Book, I'll check that out.
Check
Let
it
me
out.
ask you another question. What
Yeah.
do you want families to know about their family member who's experiencing psychosis?
Okay, that's a very good question too. Families contact me all the time. I don't only see patients experiencing psychosis. Many times I consult with family because they're at a loss and they don't know what to do. And so first of all, I try to tell them to educate themselves about psychosis so they know what their children are going through, their siblings are going through, and so that they'll know how to talk to them, so that they don't just tell them, dismiss what they're saying or what they're experiencing, talking about, oh, that's not real, or get a job, or understand what a person is going through, try to get them into the proper treatment, if they can. I think it helps them very much to speak to someone. I've been thinking about doing groups of family members of who have, because they go through their own difficulties. They blame themselves. They think they caused this, or something about their parenting might have caused it. There's a lot of self-blame. There's a lot of confusion. They need things, explained to them. And so I've worked with quite a few parents, and I'm still working with quite a few who are very, very benefited by getting that education and information and how to communicate. I think that's the biggest thing. They don't know how to communicate. So they either let the person kind of do their thing, feed them, and that's it, or they interact in a very forceful way and trying to force a person to see things the way they see things. And neither one of those is too helpful. And so, working with families on that is very, very critical.
My family trusted a peer to mentor me through after the first episode and the entry into the mental health system, through that difficult period. A peer who had projects and work for me and mentored me at the same time, and that was indispensably essential and useful to helping me in my recovery. And I remember,
how did they find that peer?
well, he was on television.
Okay.
And my sister wrote an article, thanks to Ken. His name was Ken. Ken had a newspaper, and she wrote an article for this newspaper, and in it she said, it's not like my brother had depression. I just couldn't understand psychosis. I can understand depression. I can even understand bipolar, but I can't understand schizophrenia. And this is from a family member, and, and my mother is a psychiatric nurse, so she was quick to call, 911 whenever things got sketchy. But let's keep going. What is an example of something truly meaningful that someone in psychosis has said to you that you'll never forget?
Oh gosh, so many things. One thinks. Nothing's coming. One specific thing is not one specific thing is coming. If we're talking about a case, I'll say something.
Did someone ever, where you were like, wow, that was really profound, or something like that?
Well, I can tell you something that a therapist said about psychosis and working with psychosis. I don't know why, but this is what's coming to my mind right now. Harold Searles, who was a therapist whose most of his career was working with psychosis. There are a few of us who really see it as kind of a life's mission to work with psychosis, and he was one of them, and he wrote a lot about it. And he said a few things that hit me, kind of the way you're saying. He said that the person with psychosis tries to drive the therapist crazy the same way that they were driven crazy. And so if a therapist understands this, that they're in some ways going to, at times when working with psychosis, they're going to feel they're going crazy as well, and not be terrified. Most people who work with psychosis a lot have a lot of tolerance regression, for ambiguity, for fears, for all these feelings kind of coming up in one, without saying, oh my God, I have to get out of here, I can't work with this patient. Instead saying, wow, what's happening here? I'm feeling like I'm going crazy. What just happened between me and my patient? And kind of understanding the dynamic, different ways that patients get you to understand their predicament. Searles also said once, the therapist has to sit in the most comfortable chair, so that if you're not comfortable, you're not going to be able to help people who are not comfortable. So you have to make sure in whatever way you can to feel comfortable in the work. And if you're not, I recommend that you get supervision or counseling, from someone who can help you see what is going on when you're working with these cases that aren't always easy to understand and to reach. Now, we're talking about hallucinations, delusions, more positive symptoms that are forms of communication and meaning making. But many people who experience psychosis don't exhibit hallucinations and delusions. They exhibit what we call negative symptoms, which are the lack of motivation, the lack of social interaction, the lack of pleasure, a lot of lack. And they can be even more difficult to work with, because there's the hallucinations, the delusion, they're lively, they're active, they're communicative. You get in there, you engage with them. Whereas the person who's exhibiting negative symptoms is much more withdrawn and not responsive. And so it requires a very different approach than working with what we call positive symptoms.
Tell us about that approach to the negative symptoms.
So first of all, it requires a lot of patience and a lot, what it will do in the therapist, what it will create in the therapist is a feeling of being unnecessary, or this person is just not seeing you as useful. And people in my profession who are helpers, we want to feel that we're helping. We want to feel that people see that we're helping, or we want to help. And a lot of times, at least in the beginning phase with these people, there's nothing. They won't initiate anything. If you ask them questions, they'll answer with one word, and then you're left again, like you have to carry the whole thing, and you can't just do that. So people give up, or they feel like there's nothing I can do with this person. People actually give up more with this kind of patient than with the patients who have hallucinations or delusions.
After trying to engage a person in that predicament and being unsuccessful, you're getting one-word answers. Have you ever tried okay, we're just going to sit together in silence?
Yes, I have.
Tell us about that.
In my book, I give an example of a patient where I sat in silence for six months. We just sat and looked at each other, and I didn't want to impinge. The important thing is not to impinge on someone for whom the trick is, when you see someone like this, you think they want nothing, but really what they want is that they're defending themselves, that they see contact as dangerous, and this is the way they're protecting themselves. So if you see that that's their motivation, it's not like they completely lack motivation, it's that the motivation is self-protective. And so you have to work very slowly and build up that trust. And sometimes it will mean just sitting with the person, and you convey a lot without words. A lot of the treatment in these cases is nonverbal. It's I'm here for you when you're ready. That kind of thing. And they can see with body language, with the nonverbal, with the consistency and continuity, and then they start opening up.
Okay, so eventually, hopefully, they'll open up a little bit. That's good. And do you find these patients with negative symptoms, are they also compounded by high doses of medication?
That not necessarily. Sometimes they're mistaken for depression because of the retreat and the low energy. And so I think the high doses of medication are usually given to people who have active hallucinations and delusions, even though they work better on hallucinations than delusions. 50% of people who are given antipsychotics stop taking them. And you have to ask yourself, why is it that so many people stop taking these drugs? It's not just because they have side effects, they make people gain weight, a lot of weight quickly. It's also because it takes away their meaning making. If the meaning of their life, of the is put into these symptoms, then if you take it away without working through it, then they're going to feel meaningless. They're going to feel their life is meaningless. And so they will stop taking the medication. They prefer the pain of the symptoms than the pain of not having any meaning structure in their life.
Yes, I understand that very well. And in addition, there's something that it dulls all of our emotional experiences. And for many years, I was, to connect with other human beings, you need your emotions. You need to feel a little bit what they feel and what you feel. And then there's
that's how you feel alive. Yes.
So without that, so the reason I asked, are these patients who are very quiet, highly medicated? It's because sometimes a highly medicated patient can appear to be someone with a lot of negative symptoms or depression.
Yes, that's true. And you have to make a differential diagnosis between those who are this way because of the medication as a secondary reaction to medication, as opposed to those who have to, evolved in this way from a retreat. Evolved to retreat from life. Many of them don't need medication. They're just their protection is the retreat.
So do you think psychosis is an extremely narcissistic experience at times? In other words, like, oh, this is I'm experiencing all this, the cosmos is communicating to me, and I have these powers, etc., etc.
There is an element of narcissism in psychosis. And Eugen Bleuler was the first to recognize this. And some people say there's an element of autism or narcissism, or the self becomes the world. The world is a reflection of the self. Or Freud talked about the megalomania in psychosis and regression to an earlier state. So all of this kind of leads to the world becomes how I see it. You become a part of me. There's less of a separation between self and other, between inside and outside. And so in that sense, it is narcissistic. The world becomes, some kind of derivations of what I experience, what I see, what I understand. And so little by little, in the treatment, you start bringing the person into, yes, this is your world, and let's understand it and understand how it came about and what it means. But also there's another person. There's another way of seeing things. There's another, a world out there. But that's a gradual evolution of the treatment.
Has psychosis ever happened to you, Dr. Knafo? Dr.
Knafo, yes.
Has it ever happened to you? And if not, like, how do you think you would handle it?
Oh, wow. Well, first of all, I never had a psychotic experience. I did take LSD when I was a teenager. And so I know what it means to hallucinate. I have tinnitus, so I know what it means to have sounds in my ear. That's sometimes when I developed tinnitus, which is like a ringing in the ear, I thought, wow, this is, it helped me understand people who have voices that can be annoying or intrusive. So those are experiences that I've had. I've had certain breaks in my life, traumas in my life that help me understand that, but I've never had a psychotic episode per se. How would I be if I had one? I don't know.
You can't imagine?
I don't know.
How do you think it might manifest if you had one?
Yeah, that's a question. I think it would manifest more on the the more depressive, the more retreat side. I'm an introvert, and so I think I see the protective function of introversion, retreat. I don't like impingement. So I think it would go in that direction.
How does being an introvert help you with your practice with patients with psychosis?
Well, it helps me in particular with the negative symptoms, people, because I understand retreat. I understand, I write a lot. I spend a lot of time alone. You have to when you write, and I value my solitude. So I understand the protective function of that retreat. And so that helps me, I think, empathize and be able to communicate with people who also have that need, maybe to a much more extreme state than I do.
But at the same time, being more of an introvert, does that encourage your experience of burnout with the patients who are more flamboyant?
That's a good question. I have burnt out occasionally because I do work with a lot of difficult cases. The flamboyance doesn't make me burn out. There's just that, because of the introversion, the intensity of the interactive experience can build up and cause a burnout. The worry, the concern, if somebody's in a very difficult situation. I see them almost every day. I at least stay in touch with them almost every day to keep them out of hospitals. And so it's a lot of responsibility. It can be very intense. So I take vacations periodically from my practice because I feel like I need that replenishment to be able to come back and give what I have to give. Yeah.
All right. Now, if we have very little time left, I think about 7 minutes. So this is fine because I have only like 1 or 2 questions left.
Okay. Shoot.
So would you handle a psychotic family member any different than you would your patients?
No, I would handle them similarly. I would probably be more involved outside of, they're not my patients. So I would be involved in getting them good treatment. And I would probably stay in touch a lot more. But I wouldn't handle them differently. I would try to communicate the same way I would. Hold on.
Don't worry, everyone. She'll be back.
I'll be back. My next patient just arrived.
Oh, I see. That's good. We're wrapping up here.
So they're
okay.
They're in the waiting room. So
okay.
So your last question.
So who is your closest family member to you? Who do you feel the most bonded with?
My mother, my sister.
What if one of them became psychotic? How would you handle that?
It's just what I said. I would work to get them in really, good treatment.
I'm sorry. That wasn't my question. You already said that. My question was if your mother or your sister, I mean, how do they feel about your practice with, are they learning through you about people with psychosis? That's the question.
Yeah, well, my mother reads all my books, and she just finished reading the book on psychosis, and she was very, people who are close to me who read the book, because there are a lot of my cases in the book, and they're like amazed. They said, "Oh, this is what you do?" They know I'm a therapist, they know I'm a clinician, I'm a psychologist, but I think they don't know the extent of how involved I get, of the kind of patients I work with, and the kind of patients I've had, and the successes I've had with very difficult cases. So it's a way that they get to know me. Because I'm an introvert, I don't go around talking about it unless someone asks me. And you've asked really good questions today, I have to say.
So, okay, so now we're coming to the final thoughts section. And is there something you'd like to impart upon our humble audience?
Who is your audience? Who is your audience?
I really don't know. It's a really small, well, we have social media for people, for peers, for people, and people with diagnoses, people with
Okay.
addictions, and we also, we have some allies sprinkled in and what have you, and that's our audience. So,
Okay.
and perhaps somebody from the general public, one or two people.
So
So
parting words would just be, don't give up, whether you're somebody who is suffering, who is experiencing psychosis, or someone who's trying to connect with someone who's going through a difficult period. Don't give up. Just try to be there for them. Try to take your cues from that person, and try to get the best help that's out there. So those are my parting words.
Dr. Knafo, it occurred to me that there are 30 more questions that I could possibly ask you. So I'm hoping.
Sure of that. That
so
doesn't surprise me one bit.
So can
we
we
can
say
have a part B?
We'll have a part B. Is that okay with you, Dr. Knafo?
Yeah,
okay.
We can have a part B.
All right, great. So I just wanted to thank you very much. And with all everything that happened, no problem. We did it. Wonderful.
We did it. Thank
all
you
right.
for such thoughtful questions. Yeah.
My pleasure. So you have a wonderful day, and give a kiss to your patients for us.
And to all who listen to this. Bye-bye.
Yes. Bye.